the audience, the panel members, and thank you for joining us for a discussion on the gender disparities in healthcare and STEM. We'd like to thank the Women in Medicine Summit for their collaboration. Please sign up for their conference happening October 9th and 10th this fall. I'm Isabel Hardy, a resident physician in the US, and I'll be moderating this panel, along with Zach West, a physician in Atlanta, Georgia. Now, while the American Medical Association reports that women in the US make up 36% of the physician workforce, which is up from 6% in 1950, this still does not reflect the demographics of our society. Additionally, there's an even more drastic disparity in the number of women in leadership roles. One of our speakers, Dr. Jennifer Downs, led an international study published in The Lancet analyzing gender disparities in global health leadership and how gender-specific challenges manifest in career advancement. Dr. Jane Dacre is leading the Gender Pay Gap in Medicine review in the UK, and in an interim report, said in an article with the UCL News that the gender pay gap is 17% based on total pay. Dr. Fernanda Staniszewski writes in Science that COVID-19 has put disproportionate burden on women in STEM and asks for policies and actions to mitigate the motherhood penalty. And Dr. Vinita Aurora has worked with a group of physicians and the Women in Medicine Summit to publish a matrix on how to addend CVs in the COVID time. These issues and more will be discussed in today's conversation. Now, before we begin, I'd just like to briefly run through how the session will work. Questions on the topics have been prepared, and each question will be directed to one speaker to begin with. We encourage all speakers to join and provide their input. After the question has been discussed, we'll move forward with the next. We're very excited to see what today's discussion brings. So without further ado, we'd like to ask the speakers to introduce themselves, starting with Dr. Downs.
Hi, I'm delighted and honored to participate in this panel today. Thank you so much for inviting me. I'm an associate professor of medicine, microbiology, and immunology at Weill Cornell Medicine in New York City. And I conduct my research and teaching at the Weill Bugando School of Medicine in Mwanza, Tanzania. I received my MD from Weill Cornell and my PhD in parasitology from Leiden University in the Netherlands. And I'm board certified in internal medicine and infectious diseases. I've been working in Tanzania since 2007, and I teach Tanzanian medical students and American medical students and conduct research on parasitic worm infection, schistosomiasis, which is extremely widespread in Tanzania. I'm specifically studying the relationship between schistosome infections and susceptibility to viral infections, including HIV in girls and women. I also focus on improving girls and women's access to reproductive health care in rural Tanzania. And another major focus of my career has been training and mentoring students interested in global health careers, particularly women, from both the US and from Tanzania. I'm particularly interested in interventions to foster the careers of women scientists in global health. And for the past 6 years, I've led an initiative that seeks to understand barriers faced by women internationally that lead to their attrition from global health research and leadership, and to address those barriers so that we can retain and promote women to leadership globally. Thanks.
Thank you, Dr. Downs. Dr. Dacre, would you like to introduce yourself?
Hi, my name's Jane Dacre. I'm Professor of Medical Education at UCL Medical School in London. I'm a general physician and rheumatologist. I'm the immediate past president of the Royal College of Physicians of London, which is the oldest medical Royal College in England. It was 500 years old in 2018. I first got interested in women in medicine 10 years ago when I led a report called Women in Medicine, the Future, and my interest has been increased recently because of looking at the gender pay gap in medicine in England. And I was commissioned by the then Secretary of State to lead a project looking at the gender pay gap in England. And I can tell you, it is a substantial gap and we need to do something about it. Sadly, the gap report has not been published because it was due to be published in the week of lockdown. So I hope everybody's waiting with bated breath, but I'll give you some edited highlights during the course of the next hour. So thank you very much for inviting me. I'm really looking forward to the conversation.
Thank you so much, Dr. Dacre. Dr. Staniszewski, do you want to tell us about yourself?
Hi, everyone. Thank you so much for the invitation. It's a pleasure to be here to talk about it. I'm a molecular biologist from Brazil. I'm not a physician. And I'm a founder of the movement we called here Parenting Science. We were created in 2017 to discuss how motherhood impacted the career of women in STEM. So we've been bringing data to foster the creation of public policies to support women in STEM and to guarantee that we can try at least to decrease the motherhood penalty we see in science in general. So we are now working on how the COVID pandemic is impacting women in science, and we'll be talking about that today, I guess. So thank you.
Thank you, Dr. Stanisławski. Dr. Aurora, would you like to introduce yourself?
Yes, thank you for having me and greetings. My name is Vinita Aurora, and I am a physician and a hospitalist here at the University of Chicago, where I'm a professor of medicine, and I serve as the Associate Chief Medical Officer for the Clinical Learning Environment, as well as an Assistant Dean at the Pritzker School of Medicine. My work in women in medicine, and particularly in gender equity, spans from examining and improving gender disparities for medical trainees at the evaluation level, all the way to the leadership level, where I have participated in several studies looking at pay gap as well. My personal interest in this topic stems from the fact that I am also a mother and have a 12-week-old at home, and I already have tenure. And so I start thinking about how is it that women face and go up this path when they are in their reproductive childbearing years. At the same time, they need to make it in academic health professions. And so I've been on maternity leave during the, a portion of the pandemic, and I've had time to think about that. And so I look forward to sharing my thoughts, as well as I'm pleased to be sponsored by the Women in Medicine Summit, and I'm also a founding member of Time's Up Healthcare. Thank you.
Thank you, Dr. Aurora. Briefly, Zach and I will just introduce ourselves. I'm a pediatric resident on the global health track at University of Colorado. I got my medical degree from Emory in Atlanta, Georgia. I was actually my school's chapter president of the American Medical Women's Association. And prior to that, I worked at the NIH. I studied at William and Mary in Virginia, and I'm looking forward to a career in academic medicine. Zach, would you like to introduce yourself?
Yes, yeah. I'm Zach West. I just graduated from Emory University School of Medicine with Isabel, and now I am a resident at Emory University as well. I'm excited to get more involved in advocacy for my patients as I'm working in the pediatric population. So I recognize that the changes that we make today will affect their lives for the rest of their lives. And so I want to do what I can and learn what I can to improve the culture in medicine, so that I would be happy to send my daughter and make it easier for her in the future to join the field and go into a position of leadership.
Thank you, Zach. So getting started with our discussion. As I mentioned, the number of women in science and in healthcare has risen globally over the past 70 or so years. However, this rise does not correlate to our respective nations' demographics. This question is for Dr. Stanisławski to start. What can be done to meaningfully support women interested in science and medicine, and to increase the number of women in these fields?
Okay, so one thing we need to do is to show role models. We were talking early this week on another seminar I was participating, that several women were reporting that they feel they have to choose between their private life and the professional life. So we need to show that we can have both, because we can. So that way we can make women more willing to pursue a career in science, because that we still have a model that the scientist is a male, a white male. So we need to change that. So showing that we have a lot of very capable, very inspiring women in science is very important. When we are talking about career progression, we have a lot of things to discuss. We need to talk about the motherhood penalty. That's really important, and that's what we are doing here from Brazil. And we are starting a collaboration internationally to discuss this matter globally, because it's not an issue just here in Brazil, it's an issue everywhere. So we need to support women to return after they leave for maternity leave. So it's really important to bring data to this discussion. So here in Brazil, we showed that after the women have their child, they will decrease their productivity in considering publications, for instance. So we need to support their return to science so they can be able to sustain their career. Because at least here in Brazil, we didn't have anything related to motherhood when we are discussing grantings and fellowships. So because of our movement, we were able to create some rules in our funded agencies that will take into account the period that women are leaving for childcare and all that stuff. So I think that's really important. We need to discuss this openly. One other issue that we have that is really important is harassment. We need to talk about it, because that is one of the main reasons women are leaving academia and science and in all the fields. So we need to start to discussing things openly, and that's the only thing I think can help in all this fight we have on women pursuing a career in science and staying in science throughout their career.
Thank you, Dr. Stanisławski. Would anyone else like to weigh in on this question?
Can I just add that a lot has been talked about recently about structural racism, but I think there's a broader term, which is structural inequality. And I think one of the things that holds women back, and our pay gap report has shown, is structural inequality. There are more career barriers put up in front of women than there are men. And where the motherhood penalty comes in, that makes it worse. But you're also less likely to be promoted to the most senior positions in health systems or indeed in scientific systems if you're female. And that is due to hidden structural inequalities. And these are made up by years and years and years of working in a male-dominated set of professions. And so we need a root and branch review to make sure that women are not discriminated against in that way. And the way to do that is to collect data. So if you have data that show the inequalities, then you're in a good position to try and reduce them.
I wanted to pick up on that point and highlight that one of the issues around, even in the US, where we have 50-50 split between women and men entering medical schools, for example, but we at the professor level, only 1 in 4 currently, based on the recent reports, will make it to professor. It's really not just about numbers, it's about inclusiveness at every level and mentoring and addressing implicit and explicit bias that my co-panelists have really mentioned. And so I am all about data. I like to collect data as well, but I also want to highlight the immediacy and need of solutions. We see this in the United States, especially around issues of diversifying our pipeline. We have been trying to diversify our pipeline with more minorities in medicine for years.
We've done in the poor countries where we work, where there isn't a lot of money to support some of these other interventions, we've really learned the power of peer mentorship. We were conducting focus groups for our study, and just from the single focus group at the end of our session had embracing numbers and saying, I never realized women were facing these big, it's immediate, providing women to support, and when you lack senior role models, there's a lot of collective wisdom from your peers. So that's something also we've been starting to roll out, and there's data to support that in engineering. When peer mentorship groups were established and when they were all female, the women that were in those peer mentorship groups 2 years later went on to were more likely to be optimistic about remaining in the field. They were more highly motivated compared to when they were mixed gender. So I think that those peer female mentorship groups also are free and can really make a difference.
Thank you. Zach, would you like to present the next question?
Yeah, so actually jumping off of that, I'm going to jump around a little bit on our question list because this plays in so well with what you were just talking about, Dr. Downs. So stemming off what you were mentioning about women as role models and coaches, this can play such a big role in elevating those that they work with. So what are your experiences with your own mentors, and how did you identify who would be a good mentor? And perhaps if we have time to get into it, what have you learned about being a good mentor to other women in medicine and science in general?
Is that to me?
Yes, Dr. Downs.
Sure. Okay. My two primary scientific mentors are both men. They're senior leaders in global health, and they've been tremendous mentors, actually. They are family oriented, and I have 3 children, highly supportive, and they've been incredible. I think I've also learned along the way this concept of creating a web of mentors and how valuable that can be, because no single person is able to give you all the mentorship and have the expertise that you need. So at various times in my own career, I've cultivated and pulled from the expertise of a web of mentors, and for all different things. So for the Women in Global Health Research Initiative that we lead, we've drawn from a senior female leader who leads our graduate medical education program at Cornell, and used her expertise to teach us how we can train women and how we can train women to be mentors and leaders. At other times, I've been stymied by my research findings, and I've reached out to a senior immunologist, internationally known. And other times, I've reached out to my own female peers, somebody else struggling to raise 3 kids and do global health research. And so I think there's so much value in reaching broadly and not just saying like, this is my one scientific mentor, but reaching out to other people.
Can I just add to the concept of mentorship? Because mentorship is great and really, really supportive for the people who are being mentored, but I think we need to do more. So I'm at the other end of my career and I mentor a lot of people, but I now realize that I should be doing more. And what I should be doing is coaching them in supporting them and telling them how to do things sometimes, rather than just being that reflective mentor. And then the other is engaging in sponsorship. So where I have the opportunity to put a woman's name forward to be considered for a position, I will now very specifically do it. So I will say to somebody that you need to go for this job. And when someone asks me who might be a good person to go for a particular job, I will nominate women specifically. So not only mentoring, but coaching and sponsoring. So be strong about it.
I do want to share an interesting story that just happened to me yesterday, when I actually was following exactly that advice and also see myself more as a sponsor. I also mentor a lot of women, but also coach and sponsor. There was an amazing opportunity at the National Academy of Medicine, and I get to be a nominator, and I have a woman who I was thinking about for nominating, and she is a woman of color. And I reached out to her and said, I'd like to nominate you. Can I get your CV? And she said, well, I don't know if I can do it. Is it right for me? And I realized that, this is a two-way street, which is that, even when the gate comes for the sponsorship opportunity or the mentorship opportunity, it behooves us. And I talked to her by phone and I said, I want you to think like a man, and remember, you may not get this opportunity, but just by going up for it, even if it's a reach, you'll have your CV evaluated by the people in your field that hold the gates to future opportunities. And so I do want to say, for any young people out there, a lot of women suffer imposter syndrome all across the pipeline, all the way to leadership levels, but especially at the most junior stages in your career or at career transitions. Don't be afraid to go through the gate. Don't be afraid to ask for sponsorship. Don't be afraid to ask for coaching. You're not going to be able to do it by yourself. And so one of the key things to remember is that, you know, we don't have enough women sponsors, so we're going to have to seek out men to sponsor us. And sometimes that's important. And if you're afraid to do that, that's going to be actually an important part of you getting coached to actually overcome that fear and actually make the request.
Excellent points from everyone. Sort of jumping off of that point, as we already heard, there's been a flux in the demographics of medical school classes, such that in many places, women even make up the majority of students. Despite the increasing number of women earning their medical degrees, the percent of women in hospital leadership specifically remains in the single digits. So this question to Dr. Aurora, why do you think the leadership gap exists, and what's holding women back from leadership?
This is an important question. I think, you know, this really gets at the heart of some of the issues around implicit and explicit bias. And so one possibility that I often hear, which is a myth, is that women don't want leadership positions. And that's actually, studies have shown that that's not true. And so women do aspire to leadership positions at the same rates that men do. What often happens is that the path of trajectory of early career launch points in your career that will take you to the next step or take you to the next plateau happen to coincide with when women are often building families. And so, so you see, as my colleague has pointed out, the mommy tax at play, the mommy penalty. And so there's definitely a motherhood penalty. And so women are held back. And so you're going to see men make the jump to leadership earlier than women, as long as we still have that in place. The second is that there is also a really important bias around women leaders. And so the role of leader is, when you think about leader, what comes into your mind? You know, probably not a woman. It's probably a decisive male-dominated figure that is very confident and is able to have what we call these agentic traits. When those traits are actually in direct opposition to what people think of as innately female or innately feminine.
So Dr. Dacre summarized that basically that a lot of the education and our systems have been structured around the white male. And so we have to start addressing that and creating action to actually integrate or create solutions. Isabel, do you have anything to add from that?
I think these were all great points, and I totally agree that our medical system is sort of a round peg in a square hole, in that women are asked to conform to the standards of men despite different roles at home, different expectations from society.
Okay, and then I'll go on to the question to Dr. Stanisławski. So throughout the COVID-19 pandemic, even people in science and STEM have found themselves furloughed or laid off. Others have had growing responsibilities outside of the workplace. How has COVID-19 affected the professional development of women who occupy roles in science and medicine?
So we have conducted a study here in Brazil, asking about, we interviewed close to 15,000 scientists from Brazil. And we show that women, especially women with children, they are not able to work remotely. That's what is happening now. So during this period where schools, daycares are closed, women are the ones that are taking the biggest hit on their careers because they are taking care of children and all the house chores and everything. So we showed with this survey that only less than 10% of our grad students, there are females that have children. They are able to keep on working on their thesis or dissertations during this period of this social isolation or quarantine. For researchers, we showed that women with children only around something 20% or so are able to submit papers during this period. And when we looked at men, this goes up to 70% of men reported that they are able to submit papers during this period of the social isolation. So there is a gender effect on how the pandemic is affecting how we are working at this period. Here in Brazil, one main thing we need to discuss is race. So we also showed with this survey that women of color, they are suffering way more than white women. So we need to discuss this in order to try at least to minimize all these effects we are seeing, because otherwise there will be a huge increase on the diversity gap we have in science, not only women, but also people of color. So even though our study was conducted only with Brazilian scientists, we have almost 15 scientists that were interviewed. So we believe that is a pretty good number to show that there is a gendered and there is a racial impact of the COVID-19 pandemic in the career of scientists, not only for females, but also for males, so people of color. So we believe we can at least have some rules in our funding agencies. For instance, we showed that almost 40% of the women that did not miss a deadline regarding grantings or fellowships, they did so because the agencies extended the period for the application. So we are right now writing to our funding agencies here in Brazil requesting that as long as possible, all the deadlines be extended during this period, or otherwise there will be a difference of how women and men are able to compete for grants and fellowships. So this is the main thing we are seeing right now. And this is reflecting what scientific editors from several journals were reporting in April and May, that the number of submissions by females were decreasing. So we were able to show that both race and parenthood are impacting, and they are the main cause of this difference we are seeing on gender about submissions during this period.
Great, thank you. That's a great insight. Dr. Aurora, you and Dr. Shapiro, along with Dr. Ray, and I think Dr. Glasser, put together this amazing matrix to help adjust for COVID time that is published on the Women in Medicine website. Would you mind taking a minute to talk about that? And yeah.
So actually, I want to pick up on the point about it's not just Brazil with race. For those of us in the United States, and especially me on the south side of Chicago, Minneapolis, Atlanta, all of our major cities, everywhere, we are struggling with two pandemics, not just the issue of COVID-19, but also the issue of structural racism and police brutality against Black men and women in our country. And this actually is coupled together, and for our Black men and women in medicine in particular, especially for the women now that are at home or dealing with their children, they're suffering a mommy tax and a minority tax. And so in the midst of this, they're being asked, and not only that, disproportionate share of COVID-19 in our country does fall victim in the Black and Brown communities. And so this is an incredibly stressful time for our Black colleagues in medicine, particularly for the women. And so I've been thinking about this a lot, and I sit on our promotions committee, and with a group that you've described, Dr. Shapiro from Explore the Space, Dr. Glasser, Dr. Ray, as well as Dr. Jane from Women in Medicine Summit, we have thought a lot about the curriculum vitae, the CV, as sort of the currency of promotion, if you will. And so if that's the case, and when I sit on our promotions committee, I'm evaluating CVs, I write promotion letters, I'm evaluating CVs. How am I going to evaluate a CV unless I know exactly what, how to document the impact of somebody's COVID time as been really accounted for. Otherwise, if I just look at this, I'm looking at this deficit model where I'll see all these papers for a woman and then it fell off and I'm not sure why. And usually when that happens in promotions committees, somebody might volunteer like, oh, so-and-so had a baby. And it's sort of like they're like, oh, okay, we'll let that pass. But that's not exactly the correct model. If you think about from a structural issue, how should we be thinking about equity? And so I thought, well, what if we were to amend the CV similar to a table that gets put forth with promotions committees about what people do and account for their time. So what if we were to amend the CV with a matrix that actually allowed people to not only account for their disruptions, research that's been halted or, classes that have been converted to virtual. That took a lot of preparation and hours. That should be accounted for. Moving your practice to telehealth, as well as your novel contributions. We have seen particularly health professionals doing amazing jobs, volunteering, redeployed, doing maker communities for PPE. And as I know, our medical students here on this panel have been doing a lot of work as well in that area. And so how do we account for those contributions better, as well as caregiving? So perhaps you were at home and you had, you had a spouse or a partner who was deployed and was worried about COVID and they weren't even with you. And so you were doing solo parenting and dealing with, the virtual schooling and dealing with telehealth. So how do you better account for that time so that people have a more holistic picture of what you were doing during the COVID time? And so it might be that you were doing 6 weeks in the COVID ICU. That's enough. And so if you don't have any contributions in any other bucket, fine. It might have been that you got sick or you were taking care of other people that got sick. So these are important discussions to have out in the open, I would argue, to really promote equity as opposed to having it just be volunteered on the side or, and really just, the matrix is a way to organize your contributions, efforts, as well as your disruptions to get credit for it, if you will. And so it's available on the Women in Medicine Summit website, and Explore the Space has a podcast out about it. So if anyone wants to learn more, there's plenty of resources.
Thank you, Dr. Aurora. I want to capitalize on a point you made about women putting in more work outside of the workplace, especially during this time, and actually pull on Dr. Dacre's expertise. So Dr. Dacre, you've done a lot of work with the gender pay gap. I was listening to a discussion recently, and it was by Dr. Jim Dale, who many people know as the white coat investor. And he contended that the gap is at least mitigated by women's respective interest in pursuing other facets of their life. So for instance, home life. And that may mean taking a lower paying job at the expense of, say, flexibility. So Dr. Dacre, what does your research tell us about this pay gap and how women can confront unequal compensation to their male counterparts?
So I think firstly, it's important to recognize what a pay gap is, because a lot of people get confused about the difference between equal pay and a pay gap. So equal pay is a legal concept in the UK and has been for 50 years, and that's equal pay for equal work. But what a pay gap is the definition is that it's the average difference in pay per hour for women as a percentage of men's pay. And what that means is that as women go through their careers, because they do other things, because they have children, they accrue a pay deficit, which is actually very significant and impacts on them. And this is actually, in my view, a surrogate measure of inequality for women in medicine. And in the work that we've done, we've shown that it's really very substantial for a single profession, being 18.9% for hospital specialists, 15.3% for GPs, and 11.9% for clinical academics. Now that clinical academic number is probably an underestimate. We've also looked at how do we get over that? How do we reduce that gap? Now, the concept that you were talking about to me is unequal and unfair in a society where we have now in the NHS in England 70% of women working. And if you continue to accept that women's career trajectories and pay trajectories are slower, you'll get women leaving the workforce, and we don't have enough workforce of men and women already. So the things to do is, number one is promote more women. And I was really interested to hear Dr. Aurora's view about how you might want to promote more women and how you need to put in place mitigations to be able to promote more women. The second is the issue of structural inequality. We need to stop designing workforces that promote the white male above other people. We've just got to have zero tolerance to that. We've got to look at that right back to root and branch. The next thing is that we need to have transparency in reward and pay. So if we're paying men more for a job that they're doing, or if they're able to earn more over their careers than a woman, for example, a cardiothoracic surgeon compared to somebody in palliative medicine, then we need to make that clear so that people who don't like those discrepancies can choose which career pathway they follow based on data. Another is that the laws around this tend to be nudge laws. They're not real mandatory changes. So we need to have much stricter rules about how many men and women there are within particular specialties, for example, not just say, oh, there aren't enough women in surgery, let's think about how we might get some more. Another thing is the culture. Why would a woman stay in a workplace if she's constantly bullying, harassed, undermined, and being subjected to microaggressions? She won't. So if you want equality in the workplace, you've got to address these things. Another one is bonuses. Why should men get more bonuses than women? And they do. So we need research into all of these things to try and monitor their effects and to try and implement things that will minimize them and then see whether they're working.
Hopefully other men as well have learned what they can do on a personal, individual and institutional level to promote women, because honestly, it's time to do it. And I hope that we can come together and promote women as best as we can. So thank you so much for all being part of this panel. We really appreciate your insights and expertise. And we hope you have a nice day.